Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, a physiotherapy student at the University of Toronto. I had the pleasure and privilege to attend the annual Canadian Physiotherapy Association Congress in beautiful Vancouver last month. This episode compiles 8 interviews I conducted during the Congress with clinicians. I think this is one of the best ways to involve more clinicians in the discussion of pain and physiotherapy. Last year, I asked about their views on and approaches to pain. This year, I asked them about their feelings of treating pain, what they wish to learn more about, and a memorable experience as a clinician. I also have a student interview at the end. I have added timestamps of each interview in the episode description if you'd like to jump around interviews. Before diving into it, I just want to reiterate that Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in the episode are of individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division or the Canadian Physiotherapy Association. All right, enjoy the episode. So we're here at the CPA Congress at the exhibitor session. I connected with Florence, which I actually have met earlier at U of T in our labs. He has been a very awesome volunteer and clinician teaching us a lot of things. So thank you so much for your willingness to be interviewed a little bit about your experiences treating pain. Can you briefly introduce our audience yourself and your current practice?
Appreciate that intro. My name is Lawrence. I'm a part-time clinical practitioner, currently in the midst of completing an applied doctorate from Queen's, and I'm TAing at U of T as well as Queen's.
In your current practice, what is the most common pain that you see?
Given that my practice is primarily MSK orthopedics, great deal of pain associated with musculoskeletal, myofascial, tendinopathies, nerve-related pains. And so they're all generally attributed to a trauma or an injury. But on occasion, or more than an occasion, there's a lot of psychosocial related issues that augment or enhance or aggravate the pain.
I appreciate that addition of acknowledging the contribution of psychological and social factors. You've been TAing and helping out in our labs, and I know you know a lot, but the question I wanted to ask everyone is, do you feel competent and confident about managing and treating your patient's pain?
I think that confidence and competent is a continuous scale in my own experience in practice. There's never a point where I have come to say that, I'm at the best and I'm at the top. It's never the case because of so many factors that are involved in pain. And so I think that my treatment for managing pain is always growing and morphing and changing and evolving. It sounds a bit cliche, but I think that the reality is, because of the multifaceted aspects of pain, there's never going to be a point where I feel like I've accomplished it 100%.
Yeah, absolutely. I think that feeling is how growth is driven, to continue to evolve. So talking about evolving your approach, how has that changed over the years?
So when I look back fresh out of graduate school and seeing the change till now, I would have to say it became quite 3 or 4 dimensional to this point, where your understanding of pain was quite rudimentary and just like, he hurt himself, he has a tendinopathy, or he has a muscle tear. And so the element of psychosocial contribution to it has definitely made a huge impact on how I treat pain and how I perceive pain itself.
So that acknowledgement is a big change. How does that influence your treatment approaches?
I've always had the perspective of having a multidisciplinary approach, but now more than ever has it been a prevalent mainstay in my treatment plan. So the cross referrals to people addressing psychosocial issues has been more of a practice for me to refer to something that's beyond my scope. Definitely employ the services of the psychologists, psychotherapists, and occupational therapists that are slowly moving into that realm. And those who are physio, who are specialized in pain as well. And so my referral patterns have definitely expanded and grown and become more frequent.
How did you develop those connections of referral network?
I'd have to say the networking just was honestly quite organic. It's just through work and various placement settings that I've worked in, meeting people through colleagues. It wasn't something that I sought out. It's difficult to find someone and to assume they're a good fit for a certain patient or a client. So obviously opportunities like the CPA Congress and other conferences all over the world is helpful in that manner. Given how local I am in Toronto, I think most of my networking comes from word of mouth and referrals from colleagues.
That's amazing. Is there something about pain that you're unsure of or want to learn more about?
Oh, I think there's quite a bit of the iceberg portion of pain that I've yet to uncover. So I think at the moment I'm probably mentally divided and focused on just certain areas right now, but with regards to pain, eventually it's something I'd like to delve into and how we can address and really integrate that part of treatment into my own practice in addition to referring outward. In terms of the elements of pain, I have a very strong anatomical background, and that's where I like to sit in. And so to understand the anatomy portion and how the neurochemistry and how that's all involved with the MSK portion, yeah, that's probably something I'd need to put more time into.
Are you able to identify maybe like a topic or a course or like an approach that you're maybe want to learn first about if you ever get a time to learn more about pain?
Oh, that's tough. I can't think of off the top of my head of any formalized courses or certifications for that. I'd like to see, in regards to MSK, the neurosurgeon's perspective and understanding the varied issues that come up with nerve impingement and in relation to the spinal cord and the periphery system. It's quite anatomical and pretty straightforward, but I think there's a layer that we still have yet to really grasp.
That's cool. Yeah, something I'm interested in learning too. The last question doesn't have to be specifically pain science focused, but I'm curious if you can share a story about how you innovated the treatment plan of a patient that led to surprisingly positive outcomes.
So funny enough, when I look back at my own career, yes, there has been small opportunities where I've learned and incorporated things, but I think the biggest thing has changed is my own personal experience with pain. And so funny enough, I would have a shoulder problem or a discogenic problem, and I'd go through that own experience and then understand how I felt and empathize with what my client had felt. And I think that has driven my practice so much better because then I can relate to them on a newer level and empathize on that level and connect with the patient and client. And I think through that connection, it makes that dent into that psychosocial element. And it to some degrees helps them with managing pain when they know that you can genuinely empathize. And so, funny enough, I wouldn't recommend physios going hurt themselves to identify what things feel like. But if you draw into your own experiences, I think that really does help a lot.
I totally echo with that. There's a saying that I always keep in mind. People don't care how much you know until they know how much you care. So that's amazing that we share that as well. Thank you for your time, Lawrence.
No, my pleasure.
We're at the networking session, and thank you so much, Emilee, for being willing to be on Paincast. Can you briefly introduce yourself to our audience and your current practice?
Yeah, thanks for having me, Tiffany. My name is Emilee Whittemore, and I'm a physiotherapist. I work in Squamish, BC, and I'm a part owner of a private practice clinic there. And our mantra is essentially trying to bring the care from elite sport to our general population.
So what is the most common type of pain you encounter in your practice?
Yeah, it's a great question. I'd say we deal with a lot of acute pain primarily. But we also do see a lot of chronic pain as well. But I'd say that the majority is sort of more in that acute phase.
What do you mean when you say delivering elite care to the general population? What is the elite aspect of it?
Well, my business partner and myself, as well as the majority of our physiotherapists and clinicians, have all worked in the realm of elite sport, primarily in snow sports as well as mountain biking. And so we all have experience of operating in that space, and we've all seen the opportunities that evidence-based care can provide for successful rehab for athletes. And we want to bring that to our general population because I think if we can apply evidence-based practice, there's no reason why our weekend warrior or just even your average Joe can't get back to what they love to do.
So really the vision is to provide high quality care to everyone. Do you feel at this point competent and confident about managing and treating your patient's pain?
That is a great question, and it's an interesting one because it's something I think we think about as clinicians a lot. Because, pain is an interesting conversation, and since I've graduated, I've been working now for 10 years. The idea around pain and pain management comes a lot from these different areas, and we have to consider a biopsychosocial model when we have those conversations. And so that's my roundabout way of saying that, yes, I think to a large degree we have a lot of information out there, but I think when it comes to the individual, how we manage a patient's pain is very individualized and can be very specific to one person and their condition and what they're presenting with. So I believe there's a lot of resources out there, but I believe also the nuances of that can be challenging at times.
How have your approach to treating pain changed over time?
So I think as information comes out and as we start to reflect a little bit as clinicians and how we communicate with patients, the words we use, I think that's probably been the biggest shift for me. When I first graduated, we talked a lot about joints not moving or things being stuck or joints impacted or impinged or whatever kind of words people want to use. I think it's important that we don't label things in that sense. And so I'd say for me, thinking about the words I'm using and the messages I'm sending is a constant point of reflection. And not trying to use radicalized terms to put fear in a patient's mind, because kinesiophobia is the number one thing we try to fight and we don't want to be the reason for creating it.
That's so absolutely true, and words have such huge power in creating placebo and nocebo effects. But I wonder if you can elaborate a little more if the reason why we're moving away from the pathoanatomical language, like why, and what alternative language do you use with patients?
Yeah, it's a great question. I mean, why am I moving away from it? Because I don't want to be the reason that my patient fears movement, or I don't want to be the roadblock in my patient's recovery. I want to be the facilitator to empower them to move forward from it. So when I think about the language I use, I think a lot about not necessarily minimizing whatever's going on, because I also want to validate my patient and their concern around what an image shows or what they've been told by their physician or other allied healthcare professional. So I don't necessarily shy away from anatomical terms or the discussion around biomechanics. I think there's still a place for that. But I would say that just the rhetoric around reliance, and so you need to come to see me to fix this problem, is something that I really, really, really think about and I try to avoid creating that dependence. And so I think using more words that you can educate without instilling fear are really, really key pieces, but challenging at times, right? Unless you've been kind of educated in that space. So I'd say it's a little bit of an evolution around what words I use, because I'd say the words I used 5 years ago are even different than the ones I use today and the ones I use from 5 years from now, perhaps.
Yeah, so you want to be not a fixer, but a facilitator. But how do you get feedback on whether the words you're using are the right words to be using, since you're still constantly evolving in that area?
Yeah, I mean, that's a good question. I'd say feedback is, patient retention. And then am I able to discharge them? Are they moving forward? So are they coming back 6 months later? Well, I'm doing something wrong, personally, unless, depending on what the case is in terms of the dependence piece. But are we working through the problem? Are we progressing? Are we meeting our goals? And so I think feedback is more given over a timeline. And is that patient improving? And are they moving better? And are they achieving their goals? And I think that'll kind of lend itself to the appropriate language that is involved in that care.
Gotcha. Is there something that you are currently unsure of or you want to learn more about regarding aspects in your pain care?
Yeah, I mean, I think I'm always trying to learn, particularly in patients who have chronic pain, who come to me saying, I've seen 10 different physios, but you're going to be the one to fix me. How do I communicate with that patient in a successful way that, A, they understand that their goals need to be for them and they're going to be the ones to achieve it and I'm there to help them, versus I'm going to be the one that's going to magically crack their back and make their low back pain disappear. And so I think there's always an evolving conversation about, like, for that individual patient, what does that conversation look like? What does that language look like? Is that motivational interviewing? Is that just being there to validate? Is that making a treatment plan in conjunction with the patient? I don't know. And so I'd say when it comes to chronic pain and education around moving through and pushing through, I think there's probably always something that we can learn, particularly through there, to optimize patient outcomes, because there's always some patients you don't get through to.
Yeah. And do you ever find challenge with that clinical population where they lose trust in physiotherapists because they've tried so many and so many haven't worked, and now you're the 11th one and they're like, I'll try, but I don't really not sure.
Yeah, and I think it's like a fair point. I mean, I always tell people who tell me that, like, I'm not going to do things much different than most of those 10, but I will offer you my perspective, and I'm willing to work with you as long as you're willing to put work into it. So yeah, I do find it really challenging, and I think there's a lot to learn around pain management, and again, learning about language and how people think and what motivates them, and I think that all kind of comes into the bigger picture of pain.
Yeah, that's definitely a very important aspect and very interesting that you shared that. Wonder if you can share a story about how you innovated the treatment plan for a patient that led to surprisingly positive outcomes.
Am I doing anything innovative? I don't think so in that sense. I've drawn from what mentors have taught me. I've drawn from previous experiences, from what other peers have taught me, from what I've read. So I'd say, I don't think I've applied much innovation. In terms of a success story, I saw a patient about a year ago, multiple traumas 10 years ago, living in chronic pain, had been seeing a physio once a week, massage therapist once a week for the better part of 10 years. Has gone through several different clinics and comes to me and says, okay, well, what are we going to do manual therapy-wise to fix me? And I said, I will not be laying any hands on you, and we're going to be doing active recovery because I need you and I need to help you figure out a self-management plan. What you've been doing in the past has not been working, so how are we going to pivot? And that took a while. That took about 3 or 4 months to get a consistent buy-in from the patient. But we were able to successfully get him to a good management plan. I can see him once every 6 months now for a check-in, exercise review, exercise progression, and I think a success, and I really hope for his sake, that he continues on that path, which I think is pretty cool.
Well, that's a great story. I mean, you equipped someone with a lifetime of self-management tools to help them, and they don't have to be constantly, once a week seeing a physio anymore. That's amazing.
Yeah, I mean, I hope for them that they don't have to live their life in that medicalized fashion, because I think it's, as much as I love having a good rapport with my patients, I also want them to get out of my door and live their life, and I kind of hold true to that. Yeah.
Thank you so much for your time, Emilee.
Thank you, Tiffany.
I have the pleasure of meeting Cheng. Thank you so much for being on Paincast with me. Can you briefly introduce yourself and where you practice and your current practice?
Yeah, my pleasure. Thanks for having me. My name is Cheng. I'm a physiotherapist. I currently just opened a performance rehab facility called OT Performance Rehab, located in Coquitlam, Greater Vancouver. Just opened 1 month ago. Excited.
1 month ago. How's it going?
So far, so good. We're actually doing better than we expected, but we're hoping to help a lot more athletes, youth athletes in the area for both performance and enhancement, but also with physical rehab.
What's the philosophy of your clinic?
Well, my approach on the clinic side is we want to get from somebody who's below baseline at injury state to and above baseline and sort of stay with them along the way to guide them with that and have equipment and space ready to challenge them much more than baseline. So that's the space we hopefully created. So we're looking forward to it.
Oh, that's great. That's why the name Performance. So you talked about it's mostly young athletes that you're seeing. Is that right?
Yeah, so it's me and a friend who opened the space. We grew up playing football together. and he became a strength and conditioning coach / football coach. And we coached together for a long time before I left for physio school. So I came back rehab specialist, and he is still a strength and conditioning coach. And so growing up, we've always shared this idea of having a space where working with athletes, we both like coaching aspect of it, but also I want to help them along with the injury because that's how I got into physio. So now it finally happened.
That's a very cute story. So what is the most common, prevalent type of pain do you see in your practice?
Because we're very new, I can just tell you what I've seen in the last month, which is definitely ankle sprains and knee tweaks so far, but we definitely designed our facility to combat return to sports, pre and post orthopedic injuries. Return to sports kind of thing is the stuff I'm looking forward to seeing more and more.
Reflecting on your whole physiotherapy career, do you feel confident and competent in treating your patient's pain?
Pain I actually find challenging. I find the physical functional limitations to be much easier to deal with because I feel like I approach it from a very objective manner, and what we can measure, we can change is my approach. But when it's pain, I know it has a lot to do with things outside of the physical injury itself, and I find it a little bit challenging to communicate that to a patient, even though as I'm learning more and more about it, I think I understand it a little bit better now than when I was a new grad, but I do find it challenging.
Has your approach to pain changed over time?
Yes. I think I've become much kinder to patients and myself in treating chronic pain population. And I think I have a better communication style with people who are dealing with persistent pain symptoms. And I try to explain the pain science and not sort of be as stressed out when something isn't changing in a timely manner as much as I did like earlier in my career. But I think I still struggle with that piece, because you want to help them. And with chronic pain patients, you don't necessarily know what to expect each session. Whereas in orthopedic, your kind of expected timeline of recovery is sort of more straightforward. But yeah, long story short, I think it's getting better, but there's a lot more work to do.
I totally echo with that. It's a bit more unpredictable, a bit more fluctuation, and then with particular patients, you have to be a bit more mindful about how you approach or how you explain things, the language, and all of that.
Totally.
Yeah. So, along those lines, what is something that you're unsure of or you want to learn more about pain or treating pain conditions?
So I do want to learn more about the latest science tools that can help with pain management, because my style so far has been sort of minimal machine using to up to date state, and I'm also trained in Australia. We're a little bit more manual, a little bit more hands-on, and I like that piece of my work. But I think I lack the knowledge of maybe what else is out there in terms of helping acute pain management. But also I would love to hear more about maybe research on whether it's different communication style or even cognitive behavioral communication styles into like integrating that stuff into pain management. That'd be really cool. Yeah.
That'd be great. Maybe Paincast is a good resource to start with.
Yeah, maybe. Tell me which episode to listen to.
Over the course of doing all these episodes and reading into the literature and trying to distill the literature and put it together in an episode to help fellow clinicians, I've learned a lot about different approaches, as you said. So I think scroll through it and see what you're interested in. Like look at the topic and then you look at the description. I always put in there, in this episode we talked about this and that. And then start with somewhere that you're interested in.
Love to, yeah.
No, last question. Is there a story you can share about how you innovated or changed a little bit of your typical treatment approach for a patient that had pain that led to surprisingly positive outcomes?
I'll tell you a story about my coworker who kind of changed my approach. So because we work in orthopedic kind of injury clinics, so I've got a chance to work with a lot of like higher tech ways to challenge people, like blood flow restriction is one of the things that I learned in the last like 2 to 3 years that I really like working with. So at that point, to my knowledge, we use blood flow restrictions for specific conditions that led to muscle atrophy acutely, and for people who can't handle certain loads, right? Like post-op or something like that.
Yep.
Whereas then, so my sport chiro friend used it more experimentally, I would say. But he told me a story about this neo-A, really frail old lady who's about like 70 plus and not someone I would have imagined blood flow restriction would be good for. Because I usually tell people like this is going to get really sore and you're going to have to get used to that. And the recovery is going to be a day or two, if not longer. But we're going to still push you and this is going to be a process. And usually the young athletes totally fine with it, but I've never really thought about using it for that population. And he used it on a lady for like 2 to 4 weeks. And he said the first couple weeks it was tough, but again, he set the expectation as it being tough. And that lady felt a lot of pain relief using it, even though like the muscles are sore. I think it actually taught her partially the difference between like muscle soreness recovery from exercise to like pain, like in a negative way. So I think she was able to differentiate that. And then afterwards, she was like way more approachable into active therapy.
Wow.
And then, yeah, we were able to push her a lot,
Yeah.
like farther functionally.
That's really cool.
So since then, I'm like, we can use this on anyone who's safe.
Yep.
And we've had pretty good outcomes.
Oh,
Yeah.
That's great. I'm glad that the story got into the episode. That was a cool story.
I'm waiting for the research to catch up on that.
So research specifically on blood flow restriction on pain, or?
Yeah. Or in older generation, because I think up to this point, most research on that is, very specific, more performance, younger population, and for good reasons, probably, because on the contraindication or precaution list, there's a lot of things that probably, if you're over 75, you probably have a thing or two on that list. But, I just talked to, even this weekend, I talked to an orthopedic surgeon who's like, yeah, we use it day one post-op.
Wow.
And you would have thought risk of, like blood clots and stuff, that would have been high. So I wouldn't have thought about using it that acutely. But he's on board for it. He's doing research for it at UBC, which I'm excited to hear about. So then if that's, it's safer than maybe what I would have thought before.
That's amazing.
Yeah.
Thank you so much, Cheng, for your time.
No, my pleasure. Thank you.
So I discovered that there's another cute story coming up. Like, apparently Onkar is university PT school friend with Cheng.
Yeah, we went to school in Australia. We graduated in 2018. When we met in Australia, though, it was the first time, and we found out that we were only 20 minutes down the road from each other back home in Greater Vancouver area. Nice surprise, great friendship that we were able to form and, grow our careers together, separately but together kind of thing at the same time. Bounce ideas off each other all the time.
Yeah,
Nice.
Tell us a bit more about your new clinic.
I opened my clinic about 2 months ago, Physio for Performance, in Langley. And it's catering to the athletic population that, in my experience, has been told, like, hey, you just got to wait, stop training until the injury goes away. That was kind of my experience and why I went to physiotherapy school. When I was younger, I was Olympic weightlifting and powerlifting, hurt my shoulder, and the physio just said, basically, you can't do those exercises anymore. And I just kind of refused to accept that, so I went to school to figure out my own problem. So yeah, and then that's kind of what I cater to, that kind of also helping people that don't realize how strong they really are or are scared to lift weights, and how that can actually more so benefit their life and get over the pains that they're experiencing.
Yeah, we chatted a little bit before the recording, and I think this is a very similar passion that I have in the area of powerlifting and working out. Despite there is pain, we can do a lot of modification, and let's get
Exactly.
you stronger.
Yeah, and that's the key to it, right? When dealing with pain, it's, modify the workout, tell people what to expect, and where is it, hey, you're crossing a boundary. For that's beyond just pain, that's, detrimental. But there's a certain point that you got to push through as well.
How long have you been treating patients in this capacity?
I would say for about just over a year and a half now. I started working out of a gym first after I left my last clinic job. And I was seeing a lot of the clients there too, but I wasn't having the time or the space to actually fully provide what they needed and treat their injuries and keep them moving and keep them active. So I took the leap and started my own practice, and then just rented a room in a gym and was able to kind of do that for a little bit. And then I was like, you know what? I think I'm ready to open my own space that's going to be the center for people to come to and actually get their treatment done. Yeah.
I'm glad that you took the leap. That's a very courageous decision. Do you feel competent and confident about managing and treating your patient's pain?
I believe so. I mean, sometimes injuries linger for a little bit longer. For me, I always set that expectation like, hey, I'm not going to just do things that are going to make you feel good for the next 30 minutes. I'm going to make sure that we're actually fixing the root cause of your problem. So I am confident that I'm going to treat their pain. It might not be as fast as some other places, which like just a massage or something that might make them feel good. Yeah, definitely people leave my clinic feeling better.
That's amazing. That's, the reason why we're doing the things we're doing.
Yeah.
Have your approach to pain changed over time?
Definitely. When I first started in my career, it was about making sure the person left the clinic or left the room pain-free. And now I've realized, that was more of a hindrance because, like I said before, sometimes the person goes home, 30 minutes later, the pain's back to exactly where it was because all I did was a little bit of massage or some other treatments that they were effective, but they weren't the only part of it. Now I've added the exercise component to all my treatments, where it's like, hey, you have to load it right after. If you don't, then it's not really doing any benefit. You're going to go right back to where you were. And you're going to be in the same amount of pain in a few days. And, you're just going to be going in a circle, basically.
Yeah. So acknowledging that exercise being the more ultimately long-term solution.
Exactly, right.
Is there something that right now you're unsure of or want to learn more about regarding managing pain?
I mean, there is certain forms of pain that are a little bit more tricky. I always find motor vehicle accident patients, their pain lingers a little bit longer, and understanding exactly how to manage it and build their expectations around that. But like I said before, that's not really my target audience. I really do focus more with the athletes and stuff. So with their type of pain, I'm pretty confident, but there's always more to learn. The human body is really complicated. And it doesn't matter how long you've been a physio, you're always going to be learning new things and better ways to treat your patients and better care for them.
Is there something that you have recently learned about, like a technique or like a modification to an exercise or an approach to a particular condition that was helpful?
Yeah, I mean, like I said, it's always evolving. So I always take information from each patient and I'm like, okay, what was different with that one than this one? Off the top of my head, I can't really think of anything recently. I've incorporated a lot more thrust manipulations and stuff into my practice. That seems to have a lot better effect than I originally thought. But again, it only has a lasting effect if we get the person exercising and moving through that newfound range that we just created.
Absolutely. Is there a story you can share about how you changed or innovated the treatment plan that led to surprisingly positive outcomes?
Yeah, you know what? I've also learned to take a step back sometimes from the exercise, being aware of the full person. What is this person doing outside of this? Like I have some patients that are young parents, and so they're up all night with their kid, and then they're trying to deal with some lingering pain that they have, and I'm like, you know what? Exercise is probably not what you need right now. You need rest, you need sleep. So innovative in that sense of also just telling my patients to, go sleep, go get some rest. That's also part of the care that they need. So it's obviously not in the clinic, but, kind of guiding them that it's okay to take a step back and not have to be always active, and finding out that recovery is more than just what we do hands-on manual therapy or exercise, but it's also how you treat the body and how you refuel the body with the food you're eating, the sleep, and your recovery time.
Yeah, so it's seeing the physiotherapy treatment not only about the physiological, but so much more
The biopsychosocial.
Yeah, seeing them as a whole person that you need to take into consideration of.
Yeah.
That's amazing. Thank you for your time, Onkar.
Yeah, no problem. Thank you for having me.
Alrighty, so we're at the big banquet event of the conference, and thank you so much for taking the time to be interviewed by me. Can you briefly introduce yourself and your current practice and where?
My name is Florence, and I practice in orthopedics and sports in the private practice in Burnaby, BC. I graduated from UBC in 2005, the bachelor's program, and I've been practicing for 19 years. Over the 19 years, done a lot of continuing education. I have my diploma in manual therapy, FCAP, and I've got IMS and acupuncture and taken a lot of postgrad courses in a lot of different areas of manual therapy. I've also done some course on vestibular physio as well. Just a lot of different interests.
That's really cool. Looks like you've gotten pretty wide skill set that you can use with your patients. That's
sure.
great. What's the most common type of pain that you encounter in your practice?
Maybe because I'm FCAM physio, I see a lot of spine. I guess over time I get a lot of referrals for just neck and back pain. Could be just the repetitive strain injuries or an incident, someone lifted something heavier, work-related, or car accident. A lot of my caseload is spine.
Are they more acute presentation or chronic presentation?
It's a combination. So I have some that are acute, fresh injuries, or some have chronic, like degenerative disc disease, arthritic changes, chronic as well.
Do you feel that you're competent and confident about managing and treating your patient's pain?
Yes, based on working for so long and also taking a lot of courses. I wouldn't say that when I first graduated, but over the years of just continuing education, having really great mentors, and then taking all the courses and just like the mileage of the hands-on and the feeling, I do feel very confident in being able to not just manage, but also get to the root of people's problems, of why they have the pain. A lot of the times that I see things that are maybe degenerative, like say I have a client right now, he's degenerative disc in the neck, but over time he's had a lot of chronic injuries from when he was younger, and then he lived in a rural area, so they just did neck traction to help with alleviating his pain, and that was it helped him. But then I'm like, okay, well, let's look at the whole body, see how everything integrates, how all the pieces connect. Have you done this? Have you done any of this? No. Okay, let's try and work on improving your biomechanics, improving the strength in the core, and see if we can offload the spine. So I do feel like through the training that I have received, just a little bit more holistic in the ways you look at things.
That's great. You know, as a student, soon to be new grad, you're always thinking, how do I get there? Do you think it's just simply time and experience that basically you need to wait to improve your skills? Or
Sure.
Yeah.
For sure, there is an element of time and experience because you can't gain that. And it's about doing so many physical assessments and feeling with your hands all the different, the glides, like are you feeling this? Like what does the end feel like? All those things, it's time. But also having really good mentors to be able to help you, not being in the dark by yourself, having good support, taking formal type, like the FCAM training, it's not as popular now. A lot of people opt to do other courses because it's just very time consuming, a lot of hard work, and very costly as well. But through that, you're studying and you're practicing, you're going to these courses, you're staying accountable, right? So you're doing the practice hours. So I feel like that was one of the biggest things, like through doing that, was able to build that network of colleagues that you can talk to and just bounce ideas so you can have like your own rounds, right? You just call.
Right.
You always call and pick up the phone like, hey, I've got this, and what do you think? And you're just kind of confirming what you already thought. So it's nice to have all these people. So it's very important to do that continuing education.
That's great. Through these years, you've most certainly gained a lot of expertise in the feeling and the hands-on. I'm curious about your approach or your thoughts on pain. Has that changed over the years?
Yeah, for sure. Also seeing different types of clients and understanding that pain, it's subjective, it's perceived. Just because there's pain, I've worked with some people with chronic pain as well, just because they feel this pain, it may not be in proportion to, tissue damage. After a certain amount of time, it's become chronic. So there's a lot of psychosocial that is involved. That huge component of the fear. If I move, I'm going to hurt myself. Because pain is there to stop you from moving, to protect you as a mechanism that's in our body. But when there's a mismatch, you can get stuck in this pain pattern. So that whole piece of recognizing, okay, this isn't dangerous. If we've ruled out everything, that there's some tissue damage, and getting people moving. Just moving a little bit to build confidence and they can do it again. And a lot of it's coaching. A lot of it's just giving people confidence and reassuring them that's okay.
Yeah, so getting that radar up to sensing more of the yellow flags that are presenting in the
Absolutely.
patient.
And also you can't treat someone who's presenting like that, like with a biomechanical model. You can't touch them. You can't even do any like physical assessment. You just have to move and get them moving and get out of this acute fear phase, and then you can maybe start. I also do acupuncture as well, which I can use to reduce pain, like all these other modalities that we have. But essentially, just that education piece is very huge.
A lot more talking.
A lot of talking.
Yeah. Is there something that you're unsure of or want to learn more about regarding treating pain?
The strategies, because a lot of it, I've been referring a lot out to psych and counseling for that psychological piece of pain, right? And then if people have pain, they get anxiety, and then they get depressed, and all this stuff is this vicious cycle. So understanding that piece is like very big. I've been using my other allied health to help me, but I would like to learn a bit more about that to see what I can say or what approach I can do, what kind of things like coaching wise to help address that piece. Not everyone has the ability to go to do counseling, or because it's costly, might not be covered. So, and also insurance companies, they might not pay for those additional services. So if anything, any other kind of strategies that I can use within my scope to help address that area, or more effective ways of coaching would be ideal.
That's a good point. Something maybe in the pain division we can look into, like doing something to see if there's what we can do to equip a little more in that aspect.
And then also that mindfulness training and all that is very important. Like people who are heightened, very stressed, cortisol levels are really high. They need to also be okay with sitting in the pain and not feeding into like, okay, it hurts, but then because they're attaching it with emotion, with whatever anxiety, it heightens their pain. So that mindfulness training, that grounding, all that kind of stuff, I would like to learn more about as well.
Yeah, that's great. There's a lot of, I think, resources out there for that. Last question, is there a story you can share about how you innovated the treatment plan for a patient that led to surprisingly positive outcomes?
The very complicated, I had a client who came in, she's chronically depressed and can't get out of bed and spends a lot of time in bed. She came in because she threw her back out because she was too sedentary. So she was sitting on the edge of her bed with her leg up on the edge of the frame for long periods of time, slouched on her phone. And I'm like, that is bad. We cannot do that anymore. Just that actual position. And then staying in bed for a long time. So she came in for back pain, but I knew like, okay, there's a lot more to this. So then we discussed, okay, you gotta go back to your doctor. Have you looked at your medications? You need to go deal with that piece because that piece is your issue right now. I can help you. I addressed what is the cause. It is the positioning, absolutely. How many hours are you spending in this position? It was a long time. Other than going to work, she spends a lot of time in bed. So that piece, I'm like, you gotta get maybe counseling, you gotta, just refer, but nicely, right? I didn't say like, you gotta do all these things, but in a way where they would buy in. So she stopped sitting and doing the incorrect patterns, and I got her motivated enough to just do a little bit of activity. I said, go outside and go for a walk. Just go for a walk and get moving. Do some of the exercises. I just give her a few stretches, nothing too much. I knew I couldn't bombard her with a whole ton of exercises. I did some minor adjustments just to kind of get, because things were a little bit out, and then just sent her on her way. And I saw her only a few times because I guess she got busy and she came a few times, but she was working towards changing things. I haven't touched base with her, but I know from that case history, she needed a lot more than that. It wasn't just physical therapy, right? So the positive outcome was being able to recognize what our scope is and what the main issues are, and referring to what the other practitioners or anybody else that we feel that would be beneficial before we come back and addressing more.
So like the same back pain, you don't treat it differently because
everyone's different.
Everyone's different.
Biomechanically, I assess the same. I assess the same thing. I check like our physical assessment. We check the range, check the flags, right? Check the neuro involvement. And then based on that, your physical assessment tells you where you're going to go. Also the history. Really listening to the patient's history because they tell you exactly what's wrong with it. So the history piece is very important. So out of everything for being a new grad, I think really listening to what they're saying, you will know, will direct you to where to go.
If we let them talk enough, that itself can be therapeutic too.
It is therapeutic. A lot of people come and just talk.
Yeah.
They really do. And they just like to listen, and you tell them a funny story, and they feel better. So that's part of that. The biggest piece of being an effective therapist is being able to connect with your patients.
Absolutely.
That's number one. Your skills will come, but that connection has to be there. If your connection is not there, they don't believe in you, don't have no rapport, they don't trust you, not going anywhere. So that's my take.
Thank you so much.
You're welcome.
I have the pleasure to meet Patrick, who is a very good friend of my professor at U of T, who was a professor of his when he was doing physio school at U of T. So thank you so much for coming on Paincast. Can you briefly introduce yourself, your current practice, and where that is?
Yeah, thanks for having me. My name is Patrick Jaden. I'm a physiotherapist on Vancouver Island in the Cowichan Valley. So I have 2 clinics, both private practice, musculoskeletal,
How long have you owned your clinics?
for 10 years.
That's amazing. What is the most prevalent, common type of pain do you see in your clinics?
I treat a lot of neuropathic pain, mainly stemming from spondylosis. I have an older age demographic of patients, so more degenerative changes in their spine, creating that tightness in some of those deeper segmental muscles, and then creating sometimes some radiculopathy as a result of that.
Has that been the primary population of conditions that you treat since 10 years ago?
Yeah, I think our area where I live has a higher than average population. It's a beautiful area, so warm temperatures, and a lot of people end up retiring there. So typically I've been treating an older demographic for most of that time, for sure.
How have your approach changed over the years, if it has it changed over the years?
I think you're always looking for ways to get better clinical outcomes. So whether that be changing ways that some of the treatments you're currently doing, like finding better ways to do some of the IMS needling, finding better ways to prescribe exercises, whether that be incorporating software. I use a program, PhysiTrack, which I love, and I've been using that for the past few years. But I think it comes down to also being a better diagnostician and being able to better, more quickly diagnose people and figure out what exercises are appropriate for them, what types of modalities you're going to treat, and how long do you think that they're going to take to get better, and being able to better communicate that to the patients.
I'm curious to understand a little more about being a better diagnostician. Is that being more specific in your assessment, or being more specific in what you find in your patient? Like, what does that look like?
I think it is a few things. I think one, it's being able to choose some of the tests that you feel comfortable and competent with performing, and repeating them time and time again, and over logging all those clinical hours, you tend to get a better sense of what kind of results are normal and what are maybe pathological. And then I think just even picking out parts of the subjective history that are relevant. So being maybe a bit more concise and specific with your assessment is a big thing, and even just interpreting some of the results more quickly as well, and knowing how to adapt your assessment protocol based on the results you're getting, because it's not typically a one-size-fits-all approach, right? You're changing it based on the findings you're getting, and you just can arrive at those decisions a bit quicker if you've seen other similar conditions, right? So just that whole getting exposed to many different types of patients over the years, I think just helps, right?
I guess it's all, again, coming back to that, just get a lot of exposure and a lot of experience that over time leads to evolving of your practice and getting better at it.
Yeah, and I think one of the practitioners that I'd been at a conference with once said to me that so often he found that new grads took so many courses and then they couldn't maybe synthesize all of that information, whereas a better approach might be to take a few courses, allow yourself time to synthesize that information, but mainly learn from just the act of treating the patients, right? And be at a practice where you get to see a lot of different patients, and I think there's huge knowledge to be gained in just self-reflection of what went right with your patients, what went wrong, and then figuring out how that can inform your practice going forwards.
So at this point in your career, do you feel like you're confident and competent in treating the patients you see with this type of pain?
Yeah, I'd say for me, for sure. A lot of the patients I see too, I see on an ongoing basis, where they have chronic conditions. So, you end up seeing them, whether it be monthly or every few months. So I have that fortunate experience where a lot of my caseload is people I've treated for many years.
Is there something that you are unsure of, or something that you would want to learn more about treating pain?
I think the more you do this, the more humble you become and the more you realize how much you don't know. You think when you start that if I can just do this course and this course, I'll know it all. And there's such a vast area of knowledge for us to know in musculoskeletal medicine and just in other parts that are relevant, even psychology really that plays into our practice. And so I would say I have lots to learn. I think right now what's for me interesting would be just some of the advances they're making in AI and how that's going to interface with what we do. And so that I find a really interesting level for sure.
At last year's Congress, the Pain Science Division did a breakfast. And in that event, we were actually trying to see what ChatGPT has to say about a chronic low back pain case. And it was actually very surprising that it was able to come up with a pretty decent treatment plan. But of course, those are starters. Like, we are the people who implement it.
And I think the thing with ChatGPT and AI in general right now is that it's not going to be individualized to your patient. So that's where I still think it'll never really replace the skill set of the clinician of being able to adapt that assessment approach to your patient, take into account all the subjective history that they're telling you, and arrive at an accurate diagnosis and treatment plan, because we're synthesizing so many different inputs, and I think we take for granted how much our brain is working, but I think it can definitely have real benefits to supplement some of the areas of our practice, like maybe exercise prescription, for sure.
Absolutely. Is there a story you can share about how you innovated the treatment plan for a patient that led to surprisingly positive outcomes?
I treat predominantly an older demographic, but I still have younger athletes that come in. And so sometimes you get younger athletes that come in and maybe they're not responding as well as you think they might. And I would say that demographic of patients, what I've realized is, in terms of innovating, it's actually finding ways to engage with them, and in some cases their parents, depending on how old they are, to be able to get them motivated to treat their injuries through more active means, right? Because in a younger demographic, passive treatments aren't typically as indicated. Really, the main mechanism there is trying to get them to do their stretches, to do their strength exercises, to maybe not do a certain activity. And that can be a real challenge with that demographic. So for me, I've found incorporating different technologies, like I mentioned, PhysiTrack, being able to give them exercises in a way that they can consume easily on apps and things like that has been really helpful in that regard.
Amazing. Thanks for sharing. Thank you for your time too.
Thank you. Thanks for having me.
All right. We have the pleasure to interview Amy. Thank you for coming on Paincast. You briefly introduce yourself, your practice, and where that is.
For sure. Thank you. So I'm Amy Hunter-Nichols, and I right now am not practicing clinically. So I work at the Ontario Physio Association. I'm the Director of Practice, Policy, and Member Services. So I do use my physiotherapy skills, knowledge every day. But before that, so June 2023, I stopped working in primary care. So for 8-9 years, I worked in primary care on a family health team in Hamilton, where I did a little bit of everything. So I started there when the program first was initiated, so I developed the program.
Can you describe a little more what's your role in primary care?
Yeah, so being a generalist and starting up a program, we were trying to assess what needs are there in that community. So everyone who was part of the family health team, and even some people who weren't, looking at who didn't have access to physio, and so how could we provide that access where it wasn't before. And then from the people that we would meet, what do you need? What should we be doing? So starting to develop that, and then develop a few program areas and things like that out of that. So seeing people who didn't have access, and then trying to develop a few more concrete things that we could do for those people.
What have you developed?
So I was part of a program initiated by McMaster, so a partnership to work with people who didn't have any primary care access. So unique collaboration out of the YMCA. So we saw people again on that access front, so people who didn't have any access to care. We also started a pain group, chronic pain self-management group, the Living Better with Pain or Commence program. We did that. That was a big push to get the organization to see the need, and run with it and deliver the program, which we did, and it's been a big success. And I think the other area that is maybe a little unique that we did was that collaboration with other providers. So the family health team is really large. It serves about 300,000 patients, and we're 2 physiotherapists. So you have to kind of rethink. We did a lot of direct one-on-one care, some group care, but then also how else could we assess the needs of more people or meet the needs maybe not directly. So I did a lot of educating other professionals too. So a little bit of knowledge sharing so that I could help influence their practice where possible, or even ask the question to identify should they go to physio or something like that. So a few areas where could we embed a little bit of physio knowledge in other professions to help either direct care differently or maybe in some cases improve the care they were already delivering, like people getting care for diabetes, so the long-term care, but they would talk about exercise but not be able to do much more about it. So giving a few concrete resources and how to maybe ask good questions that might actually help people do something a little differently if they were motivated that way.
Wow, that's very important. I'm glad that you're doing that. So when you were doing that, what's the most prevalent type of pain do you see? You mentioned the chronic pain group. Is that the most common?
I would say yes. So specifically, we were working with people who didn't have access to physiotherapy. So there were a lot of people who had issues that were long-standing, unaddressed shoulder pain, back pain, other areas of pain. So in that sense, chronic or persistent pain. Yes, that was a big part of what we saw. Some acute issues too, and then other maybe more chronic disease, pain that comes along with different chronic diseases. So still other ways of thinking about chronic pain, but maybe episodic, like an MS flare or something more like that, a rheumatology flare.
Wow, so these are not easy because they're long-standing and perhaps mixing with a little bit of complication with socio-economic backgrounds, education backgrounds. Do you feel that in your role, having to serve so many people, that you have the capacity to address those complicated conditions?
Yes, definitely had the capacity because maybe there's a lot more people who need the services that we were offering, but then the people that we did meet, it made such a difference because it was so new. Oh, I didn't know this existed. I didn't know this was a thing. And also, I didn't know I could do anything and be any different than I have been for however many years it had been. So I think in that sense, yes, we had a lot of capacity for it. And then you try to, in terms of that mental capacity that sparks your openness to do it, because it was challenging in a couple ways. It takes a lot of you to provide that care when the need is so great, but then also it was really rewarding. But then on the sort of technical front about capacity, I think that's one of the reasons we went for a group program as well. It didn't replace, it wasn't, okay, now if you have pain, you must do a group program, but it did help us have a bigger resource, like a bigger capacity to see more people and work with them that way.
How would you say would be the difference between, or is there a difference between treating pain in a group context versus individually?
Yes, I think, well, so we had to advocate to include this program, and one of the things that I made the case for was that even though the content or the interventions that we delivered in a group versus one-on-one were the same, there was a bigger benefit when we delivered it in a group format because everybody could learn from each other. And so every time we ran the group, to hear how much people benefited from hearing other people. No one's situation was the same, what they exactly experienced wasn't the same, but they could really echo each other's ideas. And I think that insight, like, I'm not alone, was a big, not only source of relief or companionship, but also part of the pain education, right? So to learn about the direct experience of other people living with some of the things that you're living with.
That's amazing. You're not only listening to your therapist talking about pain, but there are other people with very similar lived experience sharing that and co-creating knowledge in a sense.
Absolutely, yeah.
What is something that when you reflect to the times when you were working in that context that you were unsure of or wanting to learn more about or wanting to change a little bit or get better at in terms of treating pain?
So one of the things that we realized pretty early on when I was working at the family health team is that we had a lot of people who definitely needed what physiotherapy could offer in terms of chronic pain, but then they also had other things that maybe were better addressed by other professionals. So in particular, sometimes I would work with someone and they had different mental health concerns that I wasn't equipped to address, and that maybe needed to be somewhat addressed before I could really help as well. So what I learned from working with my colleagues in the mental health world, just how I said that I helped spread some physio knowledge amongst other providers, they also shared their expertise and their knowledge. So I could better identify when maybe that was a better avenue to work on first, but I could also then start to learn some of the strategies that they might implement, or how did I coordinate my care with other things they were working on with their counselor, so that these different areas were working together and they found the same as well. So they might be working with someone from the mental health side of things, mental health workers, and they would have a barrier. And they're like, well, but maybe we don't know, maybe back pain, maybe you need x-rays and maybe you need an MRI and I just don't know. And so that being able to work together, because they didn't have that necessarily that physical side of things or that reassurance for the patient, and so that enabled other care to also be more effective. If we could give some of that, do an assessment with the physio, let's see what we can learn and how we can coordinate that care. And I think that went a lot further than I expected, and I learned a lot from them.
So it's great to have a family health team where there are multiple disciplinaries working together. It's actually a very interesting observation. I mean, it's not surprising, but throughout the Congress, having interviewed a couple of physios, and I do these interviews independently, but it was the same question, the idea of wanting to be more equipped in not treating, but strategies to approach mental health complications in patients come up repeatedly throughout. So I don't know, maybe something that either pain division or something else can look into to put together something. Final question, is there a story you can share about how you or your team innovated the treatment of a patient and that led to surprisingly positive outcomes?
So I think it is exactly that collaboration with mental health. So the group program, the Living Better with Pain program, we started to deliver it, but it was with two leads of the program, one physio and one mental health counselor. And so that, and again, we promoted to our organization this idea not only because it would be excellent care for the people that we were working with, but also knowledge exchange, and we would each improve our own practices. So I think it was a pretty innovative way to approach not just the treatment program, but also our own professional development and our professional capacities. And I think that extended into other people working at the family health team. And then we started to collaborate with the dietitians as well. And then the other big one was pharmacists. So I think that happens on a regular basis, but really unique to be able to learn from the pharmacists. Sometimes because they would ask questions about the different medications that they were taking. And we weren't equipped to answer that. But then what we learned as a result helped us in all our other interactions, as well as to set expectations. So the pharmacist reset everyone's expectations out of pain management medications. And so one person I remember said, it's about 30% effective, and that's okay. That's what it's meant to do, rather than I should take this pill and it fixes everything. Yeah. So this kind of knowledge, I think, were not only for the patients was that really new and provocative, but for me too.
That's great. That's an amazing environment to be equipping myself, I feel like, as a new emerging physio. Thanks for sharing that. That's an amazing model to be working in. And now that I'm further reflecting on the responses I gather, hopefully I have a episode maybe to tackle something with the psychological aspect in a very near future. Excellent. Thank you so much, Amy.
Cool. That would be a great idea.
All right, so we are in the Vancouver airport, about to go back to Toronto, and I thought I wanted to interview my conference buddy this year. We had a lot of fun traveling. So, briefly introduce yourself to the audience.
Sure. Hi guys, my name is Iris, and I'm a first-year Master's in Physiotherapy student, along with Tiffany, and I'm one of the Student Council Professional Development Directors.
So at this point in your physio career, you haven't done any placements yet, but you've had a good 8 months of PT school. What have you learned so far in physio school about pain?
So far we've learned, I think, a pretty general kind of scope of what pain is and the different types of pain. For example, you have your nociceptive, inflammatory, and neuropathic. So we've learned a couple of different conditions that these can come up in, but I think definitely we'll see more of it in clinical practice for sure.
Did you have any experience with pain in your site shadowing visits so far?
Yeah, for sure. So on one of our ACE placements, which is one of the days that we're able to go in and shadow a PT, my classmate and I saw a patient come in with tennis elbow who couldn't quite localize exactly where it was happening, and the physiotherapist we were working with was very skilled and very compassionate and got her to move her arm and her wrist in different ways and kind of explain to us as he was doing each motion what he was looking for and why he was looking for the things he was looking for, which we thought was very insightful. But I don't think we've had a patient specifically come in for just pain, just from the limited amount of time we've spent in clinic. But I know that in acute care settings, it's a little bit different. We have seen CIs ask if patients would like to press their pain button before going on little walks around the unit, and also check in with the nurses to see if there's pain medications being administered or like what types those are, as well as maybe any side effects. And that's about it.
So far, with the content you've received and these site visit experiences, how have your understanding of pain changed since entering PT school?
I think something that I've definitely come to realize is how multidimensional pain is and all of the different areas that can influence and are influenced by pain. Because before coming into the program, I personally had maybe less clinical research or exposure to different patients than some of my other classmates. And my own experiences with pain were fairly limited to my own injuries or injuries I've seen friends and family go through. So being able to learn more about complex cases and patients with different conditions and multimorbidities definitely is something that I've come to learn more about and appreciate.
Yeah, that's great. I think, if anything, it's very important to understand or have the impression that pain is a very complex thing. It's not only that physical experience of it, but it's very multifactorial, as you said, very multidimensional and multifaceted. We're talking about biomedical, psychological, social, all of these factors coming into the pain experience. So that's great.
I was also speaking with some of the other pain science division members this weekend, and I learned about how there's different debates in pain science about how different approaches to pain can be more or less beneficial to different patients. Some people believe in the acceptance of one's pain, and other people are more focused on the rehab process and getting patients to have less pain, and how both approaches are valid in their own rights. So this is something that we haven't really covered in class, but I think would be really cool to explore, and is definitely one of the highlights I learned about this weekend.
Cool. That's good. Learning something new. So what is something else that you would want to learn more about pain?
I think something that our program could definitely include more elements of might be the discussion of how to have these kinds of conversations with patients. We know a lot about the biomechanical factors and theories about how pain originates, but it might be harder in a real clinical practice setting to actually have these conversations with patients because we don't know their bodies as well as they do. And I think being able to practice these with each other in scenarios or cases during labs might be more beneficial for us.
Pain education is such a huge part in pain management, and I'm sure we'll get more exposure to it. And I mean, even me as a second-year physio and a lot of physios working still struggle on this. There's always better ways of delivering the message, always ways to work on your wording, to optimize how the message is being conveyed and perceived. So sure. That's great. Thanks for your willingness to come on Paincast.
Oh, of course. Thank you for having me.
Thank you for listening to this episode of Paincast. I hope you enjoyed it. Paincast is a freely available resource to help you learn more about pain and physiotherapy. To support our podcast, please subscribe and rate it on Spotify or Apple Podcasts and share it with your network. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.